Hi, this is Kathy Wall, and today we're going to be talking about infertility. The definition of infertility is the inability to achieve pregnancy after 1 year of unprotected intercourse. This affects approximately 15% of couples, and one reason that this can occur is because of delayed childbearing. Fertility does decrease in a woman after age 35, and some women postpone starting a family until they accomplish their career and school goals. However, a man can father a baby most of his life. So when you have a patient who comes in with infertility, there's going to be a patient history that you're going to want to obtain. The first thing is menstrual cycle in the woman. Does she have a regular period? How old was she when she had menarche? Can she tell when she ovulates? Is she aware of her fertility? Is this secondary or primary infertility? The definition of primary infertility is a woman who has never been pregnant. Secondary infertility is a woman who has had at least one pregnancy but is unable to achieve another pregnancy. If she had a previous pregnancy, what was the outcome? Has she ever had pelvic surgery? Did she ever have a pelvic infection, or did the man ever have any type of urinary infection or prostate infection? Or is there any history of any genetic condition that could be affecting the anatomy? There are several things that couples can do to try to improve their chance for pregnancy, even before they start doing different workups. For instance, a woman should avoid douching because douching disrupts the normal vaginal flora and can set her up for an infection. Artificial lubricants act as spermicides, so they should be avoided as well. Now, a woman should be aware of her fertile time. The human egg lives 12 to 24 hours, whereas sperm live 4 to 5 days. So if a couple is trying to achieve pregnancy, they should have intercourse a few days prior to ovulation and then a day or two after ovulation. A lot of people don't realize that the egg has such a short lifespan, and you can see why timing is so important. Stress reduction is also important because a lot of people become stressed. They assume, as soon as they're ready to start having a family, then it's going to happen, but sometimes it doesn't happen. Another thing that can be really stressful for a couple is the family members keep asking them, okay, when are we going to be grandparents, or when are you two finally going to have a baby? And what you can recommend that the couple says to the family is maybe just like one family member. They can say to the family member, okay, you know, as soon as we know, you will be the first to know. And then that family member can tell the rest of the family and friends, so people aren't always like calling up and asking, are you pregnant yet? That can be a real major problem with patients. Now, patients should also avoid environmental toxins. They should avoid smoking cigarettes or smoking marijuana because both of those decrease sperm production. There's recent information out about certain plastics that can also decrease testosterone production, which then would lead to decreased sperm production. Approximately 35% of infertility is related to male factor. This usually involves abnormal sperm production. And as I mentioned, a semen analysis is usually the first step that's done in an evaluation. It's the easiest and the least expensive. It will assess the volume of the semen. It'll look at the number of sperm. It'll look at the motility of the sperm. It'll look for abnormal shapes to determine if this could be one of the problems why the couple is unable to achieve pregnancy. If this is the case, then semen can be concentrated and therapeutic insemination can be done. Another problem with male factor could potentially be obstructed genital tract. This could be due to a tumor, infection, or some kind of a stricture. There can also be problems with ejaculation. One example is retrograde ejaculation, and in this case, there's a defect where when the man ejaculates, the semen flows backwards into the urine as opposed to being released from the body, and this can be corrected with surgery. So here's a picture for you on the right there. It shows a normal sperm count and a low sperm count. So you can see with a low sperm count, there's not enough sperm to make the journey from the cervix up through the uterus to the fallopian tube to meet the egg to potentially fertilize it. And decreased sperm production can be caused by several things. We already mentioned smoking, marijuana, some plastics can cause decreased sperm production. Men should also avoid hot tubs because the increased temperature can actually cause the sperm to be reduced in their motility. And that is the reason, as you probably know from anatomy, why the scrotum is on the outside of the body. So any kind of a fever can also cause decreased sperm motility. And if a man has a varicocele, which is actually a varicose vein within the scrotum, the varicocele can cause an increased temperature within the scrotum. It can also affect sperm production. We talked about the semen analysis. This person would be treated by a urologist. Okay, so let's talk about some female factors with infertility. The first one being cervical problems. Now, normally around the time of ovulation, the cervical mucus becomes very thin and watery due to the estrogen. Fertile mucus actually has channels where the sperm can swim. They can ascend up through the uterus and up into the fallopian tubes. On the other hand, thick mucus can prevent the sperm from swimming up. Now, certain cervical problems can be related to cervicitis, which is an inflammation of the cervix. It can be due to infection. It can be due to anti-sperm antibodies, in which case the woman has antibodies that actually kill off the sperm. We already mentioned the use of artificial lubricants are to be avoided because they can be a spermicide. Or there can be a blockage of the cervix, like some type of cervical stenosis, maybe related to scar tissue, or there can be a congenital anomaly, or there can be a myoma. Ovulatory disorders are probably the most common cause of infertility, and they're actually the easiest to be treated. However, there is one ovulatory disorder called premature ovarian failure, which is an autoimmune disease, and what happens is a woman goes into early menopause. It can even happen as early as the 20s. So if this were to happen, then she would have to pursue assisted reproductive technology in order to achieve a pregnancy. Other things that can cause ovulatory disorders are hypothyroidism, hyperprolactinemia, or polycystic ovarian syndrome. We'll be going to talk about that in a few minutes. There are some endometrial disorders that can also cause infertility. One example is referred to as a luteal phase defect. Now, what this means is that if ovulation does not occur, then there's no progesterone to thicken the endometrial lining. If there is a uterine infection, that can prevent implantation of a fertilized egg. There's also a condition referred to as Asherman syndrome, which is the result of usually a surgical procedure where most of the endometrial lining is inadvertently removed and will never proliferate in order to prepare to accept a fertilized egg. Another reason can be unknown. Some women have gone through all sorts of treatments and it's not determined why she has difficulty achieving pregnancy. Now in this picture, we have the menstrual cycle. And I'll tell you, if you become familiar with the menstrual cycle in this chart, you will be able to figure out infertility or even fertility. You will be able to understand more contraception and also menopause. So look down at the very bottom of the picture where we have the phases of the uterine cycle. We have menses, we have the proliferative phase, and we have the secretory phase. Now, one thing to keep in mind is day 1 of menses is actually the first day of bleeding. That's the first day of the menstrual cycle, the first day of bleeding. Okay, then you can look up to the next level where we have the ovarian hormone levels. Notice that we have the estrogen and the progesterone. Now, the estrogen peaks around mid-cycle, and it's the actual peak of the estrogen that causes the LH surge, which stimulates ovulation. Now look above under the ovarian cycle, and we see the ovary starts off with a little tiny egg, and under the influence of follicle-stimulating hormone, the egg starts to mature, and while it's maturing, it is producing the hormone estrogen. So down below there, you see that estrogen peak. Then you see approximately day 14 is when the egg is released. Now, after the egg is released, that little yellow structure there is referred to as the corpus luteum. Now, the corpus luteum is responsible for the production of progesterone. And what the progesterone does is it causes the endometrial lining to thicken. You can look down there towards the bottom where we have the secretory phase. You can see that the lining is getting thicker and thicker in preparation for a fertilized egg to implant. Now, the corpus luteum, if a pregnancy does occur, the corpus luteum stays around for approximately 12 weeks. After that time, the placenta takes over progesterone production to maintain the pregnancy. So again, up at the top, you have the FSH stimulating the egg to mature, follicle stimulating hormone. You have the egg maturing, then the estrogen level reaches a point where it peaks and it sends a message to the hypothalamus to release LH. The LH actually causes rupture of the follicle and release of the egg. So if a pregnancy has not occurred, then the progesterone level drops off and menses occurs. Now, another important thing to keep in mind if you're counseling infertility patient as far as her menstrual cycle and her fertile time is that the secretory phase, which is the time between ovulation and menses, is always 12 to 14 days. So if a woman has a 28-day cycle, like in this picture, then she ovulated around day 14. If a woman has a 35-day cycle, then she may ovulate around, day 17 or something like that, because it's always going to be 12 to 14 days between ovulation and menses. So if a woman does have a longer cycle, then that means that her proliferative phase or her follicular phase is longer. So that's kind of an interesting thing to keep in mind. So it's all about timing ovulation. Okay, so let's talk specifically about some ovulatory disorders. And as we mentioned, about 20% of infertility is related to ovulatory disorders. Now, number one, I just want to mention about the premature ovarian failure. We already mentioned that this is an autoimmune disease and it causes premature menopause. So if that is the case, then this person is going to require further treatment. Hypothyroidism is low thyroid activity. And if this happens, then ovulation is disrupted. So with the correction of the hypothyroidism, there's a chance that cycles may become normal again. Hyperprolactinemia can also prevent ovulation. Now, as you remember, prolactin is the hormone that is involved with lactation. So what it does is it prevents ovulation. It can be caused by a pituitary adenoma, which is usually a benign growth of the pituitary gland, and it causes excessive production or excessive release of prolactin. And hyperprolactinemia can also be caused by certain antipsychotic medications. So if this is the case, then that problem can be corrected. Polycystic ovarian syndrome is probably the most common ovulatory disorder associated with infertility. Now, what happens with PCOS is there that multiple follicles begin to develop, but none of them actually get to the point where they can raise the estrogen level high enough in order to cause an LH surge. Okay, so what happens is ovulation does not occur, and usually people with PCOS have a very prolonged cycle. So they don't get that progesterone effect and that progesterone withdrawal that can bring on a menses. PCOS is associated with obesity and type 2 diabetes. Usually it's recommended that if a woman does have PCO, that lifestyle changes can help to correct the problem, healthy nutrition and exercise, or she may need some ovulation induction drugs. Now this picture shows about tubal occlusions. Obviously this is a mechanical problem. The egg and the sperm cannot meet because of some type of obstruction. Now the obstruction can be caused by an infection, such as a sexually transmitted infection, especially something serious like chlamydia or gonorrhea. If those infections are not treated, then they can spread from the cervix up through the uterus, into the fallopian tubes, and even spill out into the pelvic cavity. And scarring can occur, and that can cause a mechanical blockage. Endometriosis is another situation that can cause scarring. And usually if there is a problem with tubal occlusion, then the choices for that woman would be possibly microsurgery to try to correct the occlusion, or she may be referred for in vitro fertilization. Here's a picture of endometriosis, and the definition of endometriosis is an abnormal growth of the endometrium. It grows outside the uterine lining in abnormal places. You can see on this picture it's growing on the ovary, it can even grow on the spine, it can grow on the peritoneum and the pelvis, it can grow in the vagina, it can actually be around the rectal area, and I even heard one time of a woman that had endometriosis in her lung. So the problem with this is that it creates scar tissue. Treatments are with medications or most often surgery to remove the endometriomas and to remove the scar tissue. Now there's a couple particular blood tests that are done for a woman who is having problems with fertility, and the purpose of these tests is to determine whether or not she is producing normal ovulatory hormones. So she would have a blood work done, and they would test for FSH and LH. They would also test her estrogen level and her progesterone. She would have a check for thyroid and for prolactin. Other testing that a woman can do herself to determine if she is ovulating is basal body temperature charting. Now this is described very well in your book, but just basically what happens is first thing in the morning when a woman wakes up, she checks her temperature. She does this every morning. And when she detects an elevation, that indicates that she ovulated, because what happens is when the hormone progesterone is produced, secondary to ovulation, the body temperature increases slightly. Another thing that she can do around that time is she can do an LH predictor kit where she tests her urine for the hormone LH. And if you remember, it's when the LH surge occurs is when ovulation is induced. Another test that is done to evaluate for ovulation is an endometrial biopsy. Now with this test, what they do is the woman comes into the office and a provider will take a sample of the endometrial lining. They send it off to the lab to determine if the glands that they observe in the tissue are in sync with where she is in her cycle. This particular test is usually done around day 24. Another test is the hysterocsalpingogram, or commonly abbreviated HSG. This is a test to assess for tubal patency. Now what's done in this case, again, it can be done usually in the x-ray department. It's done either by a gynecologist or by a radiologist. And in this case, there is a dye that is inserted through the cervix. And it's done under fluoroscopy, and they watch to see if the dye travels through the uterus and out the fallopian tubes and into the pelvic cavity. And if the test is positive, meaning that they could observe the dye flowing, then she has normal tubes. If a woman has another procedure called a hysteroscopy, what is done is, again, it's done in the office, and the physician would insert a scope through the cervix into the uterus, and they can actually look around and see if there's any myomas, polyps, or any abnormal structures. And then finally, the laparoscopy is a surgical procedure that's done under general anesthesia. In this case, through a scope, they look into the pelvic cavity, they look for endometriosis, they look for scar tissue, and if those things occur, then they can remove those. Now, it's really, really important that with an endometrial biopsy, an HSG, a hysteroscopy, and a laparoscopy, the woman has to have a pregnancy test done before any of those tests are done, because if she is pregnant and has one of these tests done, it can interrupt the pregnancy. So to summarize the evaluation for the infertility patient, there's a semen analysis to determine whether or not there's a male factor. There's a menstrual calendar and hormone evaluation to determine if there's an ovulatory problem. There's tubal patency tests done to determine whether or not the tubes are open. And then there's also patient teaching regarding timing of intercourse. Now, ordinarily, an OBGYN physician or nurse practitioner can start the basic workup for infertility. If it's determined that there is a major problem that's going to require more high-tech assisted reproductive technology, then that person or that couple would be referred to reproductive endocrinology. If the ovulation is the problem, then ovulation induction through the use of clomiphene can be used. Or if sperm is a problem, there can be processing of the sperm. We already mentioned about therapeutic insemination. And again, ART or assisted reproductive technology is explained really well in your book. You can read there if you want to go into more detail about that. As far as nurses go, there is a really, really important role that you're going to play with the infertile couple. It has to do with the grieving process. I just wrote down here about the Elizabeth Kubler-Ross. She was a pioneer writing about the 5 stages of grief: denial, anger, bargaining, depression, acceptance. And this is what couples are going through because they may feel like a failure. They feel like they lost the baby that they always dreamed of that they never had. And a lot of couples can get a lot of pressure from family too. So one thing you can advise the couple to do is maybe to just tell one family member, and that family member can tell the rest of the family, please don't ask us when we're going to have a baby. If we get pregnant, you will be the first one to know. So the family just needs to realize what the couple's going through and how heartbreaking it could be. Now, there are several support groups available that can be really, really helpful for couples. There's one called Resolve. It's a national support group. There's another one that's actually local in Rochester called Infertility Focus. They have all kinds of resources. They have books. They have support meetings. They even do work with legislatures as far as getting insurance coverage for infertility treatments. So that can be a really good source for people. But just keep in mind that the couple will be experiencing grief. They need a lot of counseling. They need a lot of encouragement. Again, they feel lost for the child they never had. And you need to reassure the person that they are doing everything that they can, because sometimes they want to blame themselves. Like, what did I do wrong? Why am I being punished for this problem? With this problem? Patient education is a really, really important aspect of the nursing responsibility for patients who are going through infertility, because they have so much that they have to learn. They have so many activities that they have to coordinate as far as like when testing needs to be done. They also may need to have education and about taking their infertility medications. Some infertility medications require intramuscular or subcutaneous injections that the patient will give themselves, so they need teaching on that. And again, they need a lot of emotional support. It involves a lot of listening, and they will also need assistance with scheduling of different tests and procedures. So that is all on infertility. If you have any questions, please feel free to contact me. Also, refer to your textbook. If you would like to have any more detailed information about a lot of this information, you will find it in there. Thank you very much.